Feels good being in this room. This is a great event. I got asked to speak at an event for lupus last year, and lupus definitely affects more females, and I have an interest in lupus that affects the kidney. So in my clinic, I have lupus nephritis research. But I don't know if that's about 10 or 15% males, but they had an event last year just for the males. I think a lot of times we get overlooked when we look at some of these diseases. So today, we're going to talk about caring for your kidneys. So most of us are born with two kidneys. I'm on hospital service right now at Emory University Hospital Midtown, and we have a patient who has one. He has a horseshoe kidney, where both kidneys are right there in the middle, but the majority of y'all in the room have two kidneys. So blood goes from the kidneys down through the ureters, down to the bladder. Then in males, we have the prostate, then through the bladder, urine is eliminated. So this is your nephron. This is the functional part of the kidney. Each kidney has about 1 million nephrons. So blood filtered in, blood is filtered in the kidney, is filtered out. That filtrate or that urine goes through the ureter, through the bladder, and is excreted through the body. So how do we measure your kidney function? So creatine is broken down from muscle, then we get the creatinine. So this is what is in your blood, and the job of your kidneys is to filter this creatinine and excrete eliminated from the body. So when the number is low, that means your kidney function is working is working well. It's when the numbers start building up, is when we start saying there's something wrong with the kidneys, okay? So we use this creatinine and we put into these big equations. You don't have to worry about the math. But I do want you to take a look when you look at your blood work from your physician. When you look at the lab report, look at the creatinine, then look at the GFR. So this is your percent kidney function. A normal GFR is greater than 90, close to 100. So most of my patients, they can't tell me what their creatinine is, but they can definitely tell me what their percent kidney function is. So I implore all of you all too to keep track of your kidney function. And when you go to the doctor, know you function in 90%, 60%, 30%. You have to advocate for yourself and keep track of that. So when I was in med school at Emory, we looked at the MPRD equation. We'll talk about the CKD epi equation. But both of these have coefficient for black. So for everyone else, you did the calculation and you got one number. But if the patient was a black patient, they did this other addition or this modifier, and they end up giving you a separate number for black patients compared to everyone else. So I should say reported at Emory. So we use the CKD epi equation. So when you look at your lab, this patient lab, the creatinine is 1.37, but it reports out the kidney function is 64% if the patient is non-African American, and 74% if they're African American. This patient was African American, so the kidney function reported higher for African American patients. So you might say that's a good thing that we have a higher kidney function, but when it comes to seeing a kidney specialist, getting referred for things such as kidney transplant, actually having that higher number delayed kidney care for African American patients. So at Emory in 2021, now we only report out one number. Everyone gets reported with that first number. We stop separating the non-African American and African American kidney function. So, but now at Emory, we only report one value, and a lot of hospital systems across the country are removing race from kidney function reporting. Yes. Here we go. So when you look at kidney function reporting, we put that percent kidney function into your GFR stages. So stage 1 is people with kidney function greater than 90%. Stage 2, 60 to 89. Now we report stage 3A and 3B. So 3A, 45 to 59. 3B, 30 to 44. Stage 4, 15 to 29. And stage 5, less than 15. This is a new reporting for stages of kidney disease. Most are referred to a nephrologist or a kidney specialist like myself when you get to that stage 3 area, and definitely by the time you get to stage 4. One thing that we start noticing, patients who have the same amount of kidney function, we also look at protein in your urine. So that's the albuminuria. So that's a fancy word for protein. So patients who spill more protein do worse than patients who spill less protein. So protein is supposed to be in your blood. It should not be in your urine. So if you have protein leaking into your urine, that's a marker of kidney damage and abnormal kidney function. So some patients can have an actual normal kidney function percent, but spill a lot of protein in the urine, and there's still someone that I'm worried about because they're risk of progressing to chronic kidney disease. This is the older stage. They did stage 3, just 30 to 59. They don't break the 3A3B. Most of my patients in clinic, I try to teach them this way. So stage 1, stage 2, stage 3, stage 4, stage 5. And we use the term end-stage kidney disease or end-stage renal disease when people need dialysis. And our goal is try to prevent patients from getting to dialysis. So look at rates of dialysis by ethnicity in the United States. You see Black patients compared to white patients, 3.5 to 4 times the rate needing dialysis compared to Caucasian patients in the US. But all minorities in the US have higher rates of kidney disease compared to white patients. So, but Black is at the highest amount at 3.5 to 4 times the rate, and many studies showing the same thing of needing dialysis. So why do people start dialysis? Why do people have kidney disease in the United States? Number 1 is diabetes. Number 2 is high blood pressure or hypertension. And I'm incorporating some of the questions that people sent ahead of time into the slides. And one was about alcohol in the kidneys. And we get this a lot. Alcohol does not really directly affect the kidneys. It is directly toxic to the liver. But the number 1 cause of kidney disease in the United States is diabetes. Number 2 for kidney disease is hypertension. Alcohol can make both of those worse. So social alcohol is okay, but heavy alcohol use definitely can make the blood pressure higher and definitely can make diabetes harder to control. Number 3 for kidney disease is glomerulonephritis. So those are special inflammatory diseases in the kidney, like lupus nephritis, HIV-associated kidney disease, FSGS, focal segmental glomerulosclerosis. That's a special type of kidney disease you can get, and one that I do some research in along with lupus nephritis. Other things is that last at 10%. So one of the questions someone asked about kidney stones. So kidney stones, if they're bad and recurrent, can definitely cause people to have chronic kidney disease and could definitely lead to dialysis if they're not taken care of. Someone asked about bilirubin. Their levels of bilirubin are high. Does that affect the kidneys? Bilirubin itself does not affect the kidneys, but conditions that can make the bilirubin level high. Sickle cell could be associated with kidney disease. Liver disease. I'm on hospital service right now. We have somebody with hepatorenal syndrome where their liver is shutting down and it's making their kidneys now starting to shut down also. So bilirubin itself is not toxic to the kidneys, but if you have underlying sickle cell or liver disease, that can definitely affect your kidney function. So chronic kidney disease in the United States affects more than 20 million Americans. The percentage is pretty stable right now, about 14% of adults. But when you get above the age of 65, though, it's about a third, about 33% of adults will have chronic kidney disease. One reason things like hypertension, diabetes are more prevalent in older Americans, but also after about the age of 50 or 55, we all start to lose some kidney function as a natural part of aging. CKD prevalence was highest among Black individuals, up to 18.9% in that study. Overall, Black individuals, 18.9%. So almost 20% of Black adults have chronic kidney disease. End-stage kidney disease are needing dialysis in the United States. African Americans, we account for 13% of the population in the US, but we account for about 30 to 33% of patients who are on dialysis in the US. So there's definitely a big disparity that we only account for 13% of the population, but about a third of the people on dialysis. We have 50% higher risk of chronic kidney disease and 3.5 times higher likelihood of progression from CKD to end-stage renal disease needing dialysis. And that's a picture of someone on dialysis, where our goal is to try to prevent people from getting to dialysis. I'm gonna have a whole nother talk about dialysis. Everyone cannot be prevented from making to dialysis, but we definitely do not utilize transplant and home dialysis enough in the US. So even if you do, we need to talk about other options too. Kidney disease in American minorities, so other things, socioeconomic factors or access to healthcare. A lot of us, unfortunately, are uninsured or underinsured. So your insurance status, like having Medicaid. I'm at Emory Midtown. We had the highest percent of Medicaid in the Emory system. Food deserts. I work at Emory Midtown, but we have 4 Emory dialysis units, and I go to 3 of the Emory dialysis units. And 3 out of our 4 dialysis units are what we consider food deserts. They're not in places where people have access to healthy food, using a lot of stores such as Dollar General and Family Dollar to get access to food. So we definitely have that issue. Pre-dialysis clinic care. So we use those percent kidney function, use your creatinine, your percent kidney function, but that's how your primary care doctor determine when to see you to a nephrologist. So once you get to the nephrologist, that's how we determine when we start getting ready for home dialysis. That's how we determine when to refer somebody for kidney transplant. So if the number was always higher for African Americans, it delayed African Americans being referred for things like that. So that's one reason why we work so hard to remove that nationally, our national recommendations, and also here in Emory. Now, another one we'll talk about genetics, and we're doing some research in this, but APOL1, this is only for Black patients, but we noticed this genetic defect has been associated with more chronic kidney disease and more severe chronic kidney disease, leading to the need for dialysis. Yes. And I want to talk about a little more APOL1. So we talk about evolution and mutations, and we know that sickle cell was developed as came through as a mutation to combat malaria in Africa. And now we think APOL1. This is pretty new when it comes to nephrology. When I was a nephrology resident and fellow at Emory, we were not talking about APOL1. So this is definitely new research within the last like 10 to 12 years. But Trypanosoma brucei causes African sleeping sickness. So they think this mutation developed to protect against African sleeping sickness. But now what we notice that patients from West Africa, well, people from West African ancestry have a high rate of having this genetic defect. And now studies have shown that this might explain, we still got the socioeconomic stuff, we still got the insurance issues, we still got the food deserts, we still got issues with access to healthcare. But now we know that also there might be some genetics that explain why African Americans have more kidney disease compared to others. And this is just looking at APOL1 and the effects on the kidney. Things like diabetic kidney disease, it doesn't seem like it's associated with that. But hypertensive related end-stage renal disease or kidney disease is very high affiliation with it. Lupus associated kidney disease, this genetic defect has a very high correlation with it. Kidney transplant patients, transplants failing or rejecting. Now we think APOL1 is associated with higher rates of that. FSGS, focal segmental glomerulosclerosis, which is one of those special inflammatory conditions. I think the most famous person we know with FSGS was Alonzo Mourning, the Miami Heat basketball player that had the kidney transplant. He had FSGS, and it's in higher rates in African American patients. HIV-associated kidney disease. We used to say we only see this in Black patients. Now we think we know why. That having HIV, but affecting the kidney is a lot higher in African American patients. So what can I do to prevent kidney disease? That was one of the questions. So first we got to look at the risk factors for chronic kidney disease. Diabetes, number 1. Hypertension, number 2. So controlling your diabetes if you have it. So the goal A1C, so we talk about your 3-month average for your blood sugar. Try to at least keep it less than 7 when we talk about chronic kidney disease. Now there's some data about maybe getting less than 6.5 or some other things, but definitely less than 7 when it comes to chronic kidney disease. Hypertension, high blood pressure. Some of us, high rates of hypertension in our patient population. My family history is very strong. I've had high blood pressure since I was in my 20s, but you can control it though. You can take your meds, diet and exercise changes. Just because you have it, you don't have to Let it run hot, lead to kidney disease, lead to heart attacks, lead to strokes. Coronary artery disease, so having heart disease is a risk factor for having kidney disease. Obesity, having a BMI especially above 30 is associated with kidney disease. Genetics and family history. But now even more specifically, we know APOL1 might be one of the things that we see. Older age is associated with kidney disease. You can't really prevent that. Chronic illnesses, HIV and lupus. But if you have a chronic illness, make sure you treat it. Make sure you control the lupus. Make sure you control things such as sickle cell. Not getting screened, and that's a big thing I'm passionate about. It's about community engagement and education when it comes to patients. We see a lot of patients what they call crash onto dialysis in our hospital, especially at Emory, Midtown, especially at Grady. These are patients who have never seen a kidney specialist in their life until they get to the hospital. And a lot of these guys are young. I got one right now who just started. He's only 31. And it's hard telling someone when you meet them in the hospital for the first time, you need to start dialysis. So, you know, this is something that for years, if you have had your annual physical, had your creatinine check, been able to follow your kidney function, but we call these crashes. And we see this a lot more, especially in African-American males, that they don't go to the doctor at all, and they show up with a creatinine of 10, kidney function of 2 or 3%, and we need to start dialysis. Yeah. So please get screened. And the nephrotoxic medication. So this is one of the questions that came up too. Motrin, NSAIDs. So NSAIDs, Motrin, Aleve, Advil, BC powder, Vidi powders, naproxen. All those medications decreases the blood flow going to the kidneys. There's some other special things they can cause too, but the main thing is decreasing the blood flow going to the kidneys. I've seen so many patients where their chronic kidney disease is only because they took a leave on a regular basis for like 20 years and cause progressive chronic kidney disease. And the issue with that, when somebody take a high dose of Aleve or Motrin, they sick in the hospital, usually that's an acute kidney injury. That's reversible. We stop it, give them some fluids, and they reverse. But this chronic use for years, a lot of times we can't reverse that. So definitely be careful with how much pain medications you take. We like Tylenol. Tylenol might affect the liver. You gotta be careful how much you take, but it doesn't really do anything bad to the kidney. But a lot of times patients say Tylenol doesn't work. You gotta mix in some of the Tylenol and please decrease your NSAID use. Then another medication, chemotherapy. At Emory Midtown, we just opened this Winship Cancer Institute building at Midtown. And I'm on the pharmacy committee at Emory Midtown also. There are so many of these new cancer drugs that are coming out. They're doing a lot of research in cancer. But a lot of these new drugs have bad side effects when it comes to the kidneys though. Unfortunately, most of the time these patients need these medications, but a lot of these medications have bad effects on the kidneys. So predicting who's going to progress. So let's say you got the diagnosis of chronic kidney disease, stage 3, but I'm trying to keep you from progressing to stage 5 and the end-stage renal disease or end-stage kidney disease needing dialysis. So level of GFR when I meet you. So that's your function at baseline. Get screened so you don't come to me too late. It's a lot harder trying to take care of a patient who shows up for the first time and their kidney function is only 24. If your kidney function 55 or 50, I got more time to work and try to do things to try to prevent the progression of your chronic kidney disease. The protein in the urine. It's supposed to be in your blood, not in your urine. There's certain things we can do medication-wise I'll talk about to try to decrease the amount of protein in your urine. High blood pressure, hypertension, getting that under control. I know sometimes we don't like to take medications. Some of our medications have bad side effects. Even some social side effects. So with some of our blood pressure medications, but we have to take the meds. Also, we can do lifestyle modification, losing weight, exercise, and low salt diet will definitely help. Myself, I used to be on 3 meds. Now I'm down to half of 1. I lost about 15 pounds. So I'm stepping, watching my steps, and trying to cook just a little bit. So definitely let's eat now. Predictors, we talk about race, but now we think more than just being Black. We know it might be some genetic factors now with APOL1. Men definitely have higher rates of progressing from early CKD to needing dialysis. Advanced age are higher risk. Obesity, smoking, poor glycemic control, or diabetes control. ongoing nephrotoxic medication use, so using those pain meds like the NSAIDs on a regular basis. Certain antibiotics can also affect the kidneys, but usually you're not on antibiotics for a very long period of time, and definitely some chemo. So effects of medications on kidney health was another question. So definitely the NSAIDs, the pain medications, you can definitely do something about, but also be mindful of some side effects you can have for antibiotics and some chemotherapy too. Hyperlipidemia, cardiovascular heart disease. I think the kidney is the most important organ in the body, but if the heart isn't pumping blood to the kidneys, you will have decreased kidney function. We see that a lot, patients with heart failure. And actually a lot of young African-American males with heart failure in their late 30s and 40s now, and they're having chronic kidney disease. So the management, you got to determine the cause. That way you have to see us. You don't treat everything the same. So treating someone with lupus nephritis is different than treating somebody with diabetes or high blood pressure. At least annual evaluation of GFR. That's your kidney percent and the amount of protein in the urine. A lot of PCPs, primary care doctors, will only check the blood work, the percent kidney function. You gotta advocate for yourself. Make sure they check your urine also and look at how much protein you have in your urine. Because if you can have a higher GFR, like somebody with lupus, you can have a kidney function that's 90%, but if they're not checking the protein in the urine, you could be missing active lupus nephritis. That's someone that needs to be seen by me in clinic sooner than later. And I said annual, but if your CKD is higher, like a CKD stage 3B, stage 4, you need to see me more often. And our CKD stage 5 patients see me every like 4 to 6 weeks. Because the goal is, just because somebody's GFR or kidney function is less than 15 doesn't mean you have to start dialysis right away. Our patients been seeing me in clinic for years, over 5 years, who we see each other every 4 to 6 weeks. They do the blood work, we change up their diet, we change up the meds, and try to keep them off dialysis. Avoid further insults. So things such as the certain medications like the pain medications will slow the progression of CKD. Somebody asked a question about complications. So what other complications does the kidney have on the body? It can make the blood pressure worse. So definitely worsening blood pressure. Anemia, the hormone EPO that make your bone marrow make red blood cells, that comes from the kidney. So if your kidney function is low, most of my patients have anemia. A lot of patients on IV iron and other medications to get their blood count up. You can have abnormal electrolytes like high potassium and high phosphorus levels. Someone asked about diet in one of the questions. I'm going to talk about it a little later. But when you Google chronic kidney disease, a lot of times they'll have the diet for people with severe chronic kidney disease. They pretty much have you not eating anything. We should do it based on the lab. So people with early CKD are not as restrictive on the diet as patients with later CKD who are almost on dialysis. I'm very strict on the diet in those patients. So potassium building up, avoiding things like bananas, oranges, tomatoes, and potatoes. So phosphorus building up, avoiding milk, dark colas, things like that can help with severe chronic kidney disease. Then management, we're not going to talk about end-stage renal disease that much today, but preparing for dialysis and definitely more home dialysis is needed in the United States and transplant referral when appropriate. I did not win that Powerball yesterday, but I thought my chances were high. I've been on the road. I had 3 patients transplanted this summer, but good luck on transplants, but I didn't win last night. Treatment recommendations, so our guidelines, blood pressure. So we talk about the systolic blood pressure, that's the number on top, diastolic blood pressure, the number on the bottom. Especially if you have chronic kidney disease and a lot of protein in your urine, you want that as low as possible, less than 1/3/80. If you have chronic kidney disease, but no protein in the urine, you probably get away with less than 1/4/90. There's some recommendations that saying less than 1/3/80 for everyone. But I have to look at the side effects and the medications for my patients, so I individualize that, especially if someone doesn't have a lot of protein in the urine. And some of my older patients too, risk of falling if we drop the blood pressure too low. Low salt diet in everyone with chronic kidney disease. Actually, even if you don't have chronic kidney disease, everyone I think should be on the low salt diet, less than 2,000 milligrams of sodium per day. I think we did pretty good today. Maybe the salsa, but everything else seemed to be pretty low salt today, low sodium today. So once you're diagnosed with chronic kidney disease, besides controlling the blood pressure, besides controlling diabetes, getting the A1C less than 7, there's certain medications that we know, especially if you have protein in the urine, that you need to be on. So ACE inhibitors, ARBs. So these medications like lisinopril and losartan. But I know some of y'all are on Facebook and on TikTok, and you see these horror videos about people having side effects with medications like lisinopril. All medications have possible side effects. There's this thing called angioedema with lisinopril, where you can get the lip swelling and the possible swelling of the tongue, and being in the hospital a lot sometimes. But those medications are great when it comes to decreasing the progression of chronic kidney disease, these specific blood pressure medications. So I had to do a lot of education with some patients who, after they Google and see the videos, they're a little nervous about taking those medications. But we take them, we can follow them, we can stop the medication if you have a side effect. And someone put in a question about the latest and the greatest. So ACE inhibitors like lisinopril and losartan, we've known about this since the 90s. But there are some newer medications, and you see these TV commercials talking about SGLT2 inhibitors, things like Farxiga and Jardiance. You see these TV commercials. These are really, the data has been really strong with these drugs, even better than things such as lisinopril and losartan, about decreasing the progression of chronic kidney disease and decreasing the protein in the urine. And these drugs have been around for a while to treat diabetes, but these even patients without diabetes, using these for chronic kidney disease. And there's another one for specifically diabetes and chronic kidney disease, Corindia. It's a medication that helps with inflammation and fibrosis in the kidney. I like the data on Corindia, but I definitely like the data when it comes to Farxiga and Jardiance, the SGLT2 inhibitors. So these are some questions I didn't toward the end. So what type of foods should I avoid to maintain a good kidney health? So do you have diabetes? Do you have hypertension? Controlling that. So low glucose diet, low sugar diet if you have diabetes, low salt diet if you have high blood pressure. Low sodium diet for everyone though. Another question, are creatine supplements bad for your kidneys? If you do not have chronic kidney disease and you're trying to make some muscle mass and use it before you go into the gym, probably doing a low dose of creatine is probably not going to do anything for you. Anything bad when it comes to your kidneys. If I've taken some in the past, and if you read it, they want you to take it before the workout, after the workout, when you first wake up in the morning, before you go to bed. That could be a high amount of creatine that you're taking there. But if you're taking a supplement before the workout or right after the workout, that's probably not a severe amount of creatine that you're taking. So if you have chronic kidney disease, do not take creatine supplements. Go to your doctor, get your physical, look at your lab, but if you have chronic kidney disease, you can't take the creatine supplements. It can make the creatinine higher. Another question, are heavy metals associated with kidney failure? Especially lead probably has the biggest data when it comes to being associated with chronic kidney disease. Also, there's some research that looks at like farm workers in Central America, even some in the United States, been associated with increased rates of kidney disease, and some of that could be heavy metal associated. Is urinating a lot a sign of trouble? It could be a severe kidney disease. Get your blood work checked. Patients sometimes, especially when they get this late stage 4, stage 5, and we're almost talking about dialysis, they say, I'm urinating more than I ever urinated in my life. How can my kidneys be going bad? The issue is that your kidney is supposed to regulate when you eliminate water or urine, and also, so keeping it also. So that's a sign, actually, some of those patients is that their kidneys are failing and they just can't regulate and maintain urine when they need to. So they urinating all day long. Prostate issues is probably the biggest one I see in African-American males when it comes to urinating a lot, especially at night. Maybe one time at night it's okay to get up and use the bathroom, but if you get up more than that, you need to get prostate checked. Urinary tract infections could be associated with increased urination. There's some rare things that could be associated with increased urination, but fluid intake also. So I'm going to talk about daily water consumption. We want you to drink water. If you drink a lot, it got to come out. So it could just be as simple as cutting back on your water intake sometimes with fluid intake. And also the type of fluid. Caffeine is definitely associated with making you urinate more. So you can cut back on your caffeine use too if you urinate a lot. And someone asked about daily water consumption recommendations. So we deal in liters a lot. I know a lot of times you might deal in more ounces. So if you're doing 8-ounce cups, probably about 7 or 8 a day, that gives you about 2 liters of water. I know that's hard to do, but you get at least a liter and a half in. Now, someone asked about kidney stones. Now, my kidney stone patients have to get 2 liters in a day. Getting an increased water intake for kidney stones will prevent kidney stones and prevent people from having recurrent kidney stones. And another question, how does kidney disease in African Americans differ in diagnosis and treatment, particularly Black men? When it comes to diagnosis, we talked about they had the race in the kidney function reporting. So now most centers are starting to remove that. In the treatment, how does race play a factor? We see more severe chronic kidney disease in African American patients. Now we think it might be related to a large percent to APOL1 and genetics, but also we still have a lot of social and economic things that play a role too, in particular Black men. Black men have higher rates of kidney failure than Black women, higher rate of being on dialysis compared to Black women also. Actually, Black males is the highest rate of kidney failure in the United States. Health communities concerned about prevention, research, and decreasing progression versus having patients in dialysis centers. I get that question, I hear that term a lot. They was like, well, the kidney doctor just drove people on dialysis. I will have to say, I have seen some instances where they treat the number and not treat the patient. Just because your kidney function is less than 15% does not mean you need to be on dialysis. People come to me sometimes for a second opinion, and we can treat for years by changing meds, changing diet, following labs before we need to go on dialysis. The other thing is referring patients for kidney transplant earlier. I have patients who went straight from seeing me in the clinic to kidney transplant without ever going on dialysis. So that's something we do not do enough of either. Prevention and screening, education. So I have a group kidney disease screening and awareness program. So that's actually a picture from South DeKalb Mall health screening that we did. And we're doing one at Brookhaven. They having a town day pretty soon. I think it's the 3rd weekend of October, another screening event that we're doing. But there's definitely things where we can get out, spread the word, even yourselves, your churches, your fraternities. You can definitely have things where we do screening events or even education about kidney disease. Kidney disease does not get as much education as some other things, such as heart disease and cancer and things like that. So definitely spread the word about kidney disease and screening. Research. I'm an Emory faculty member. We also do research. So unfortunately, when you look at NIH or government research, usually at the bottom is nephrology and geriatrics. We definitely get ignored when it comes to amount of research dollars compared to things such as HIV and cancer. They get a lot more research when it comes from the government. We are doing research, but we definitely need more people doing research in kidney disease. And even y'all in cited groups, I would definitely tell Dr. Parker to advertise for some of our research studies. I'm actually doing a study now in lupus nephritis, but we're about to start one at APOL1, looking at APOL1 in patients with chronic kidney disease. And I was part of the study in New England Journal of Medicine that came out this year looking at APOL1 and FSGS. So Emory was the site, and I was the co-investigator for the Emory site. Decrease in progression versus having patient dialysis centers. This is a paper we did looking at pre-ESRD care, so trying to look at care before people get the dialysis and people with multiple myeloma. So multiple myeloma is higher rates in kidney disease, and you actually can ask Dr. Cobb, I guess at the next event about multiple myeloma, but it definitely affects the kidneys, and we see Black males have a higher rate with multiple myeloma with kidney failure. Now, when it also comes to prevention, comes to research, comes to attitudes about trying to keep patients off dialysis, I'm big in diversity, equity, and inclusion efforts for the American Society of Nephrology. And things that we can do, that we can all do, we got a pipeline problem. When you look at the amount of physicians in the US right now, African American males are the only group that's about the same compared to the 1970s. The United States population has doubled since that point. In other groups, you see the amount of doctors going up. like the amount of African-American female doctors has almost tripled since that time. So please, and do things that we can do in the community to encourage our African-American males to go from high school to college, look at science careers, look at medicine. I know there's some other things that people will make a lot more money or faster money than going through college, then 4 years of med school, 3 years of residency, and 2 years of fellowship. But we definitely need more representation when it comes to medicine, when it comes to nephrology, having more African-American male serving as providers who can help with prevention and research in kidney disease. And things coming up, Kidney Walk is this Saturday at Atlantic Station. People can look at the NKF website. So the Atlanta Kidney Walk is this Saturday. World Kidney Day is every March, and I think it's the second Thursday or the first Thursday in March. Take a part, have events at your church, have education, have screenings. We get invited to churches to do things for World Kidney Day. The American Association of Kidney Patients, AAKP.org, they have a lot of information when it comes to chronic kidney disease. If you want to learn about it or information you want to share at your events, Kidney Walk also, National Kidney Foundation, kidney.org, also has a lot of information. The American Society of Nephrology also does a lot. They definitely more on the research side. And here at Emory, we have education when it comes to patients with late stages of chronic kidney disease, about their dialysis options. And our lives begin to end the day we become silent about things that matter. Kidney disease, health disparities, are things that matter and doesn't get enough attention. Thank you.
Yeah, we're gonna have time for a few questions, but before we do that, I just want to go over a few things in terms of, by the way, thank you so much for a great presentation, Dr. Cobb. We just want to go over a few things in terms of just how to form your questions, right? So we want to make sure that you are asking questions versus making statements or a commentary, okay? And you know, and I know he's got to go.
Some commentary.
Yeah, you got to go back to work. So is that one over there on the screen? Okay, cool. All right, so we can start with a question over here first, since that mic is working, and then we'll try to get this side. We're going to work from side to side, so we'll have a good representation for both sides.
Dr. Cobb, it sounds like there are trade-offs that have to be made if you are being treated for kidney disease as opposed to some other ailment. Since you said there's side effects associated with every drug. How do you decide which is most important? Do I do something for my kidneys, or do I do something for my heart? Or do I do something for whatever other ailment I might be having? How do we decide, or how do you decide? Or help us decide?
I'm on hospital service right now, so the big one is the cancer drugs right now.
Right.
Some of these patients are on their 4th and 5th line of chemotherapy, on their last options. We need to treat the cancer. I can do things to try to maybe give them fluids, give other medications to try to flush the chemo through. But something like that, you definitely need to treat your underlying disease. Now, some of the other things that I get in clinic on a regular basis, like your hypertension and your heart disease and some of the trade-offs. So erectile dysfunction is probably the biggest one that I get when it comes to men taking their blood pressure medications. Give me a chance, work with me. There's like 7 or 8 different classes of blood pressure meds. So before you give up on all the meds, I can change to a different one or cut down on the dose, and we can work with each other on that. Yeah.
All right, good.
A lot of times they just stop taking everything, and I won't see them anymore for a while.
We don't want that.
Dr. Cobb, thank you for your presentation. I thought it was great. We have 2 kidneys, correct? How do you discern which is which when you say you have kidney failure? And then when you get a transplant, you only get 1 kidney. Which one has failed, and how do you know?
I get that one a lot. So you're correct, that blood tests that we measure, both kidneys are being affected the same by things like high blood pressure, by diabetes, from lupus. Only time that you usually see where one kidney is affected more than another, things like kidney stones. Like some people may have kidney stones all in one kidney, but not in the other. You can have cancer in one kidney, and we have to take out one kidney, and you only have one kidney left. Now, the main reason why with transplant, you only get one kidney is because, the amount of kidneys available. So we don't have enough people on the donor list and not enough kidneys being available for kidney transplant. So you can use that one deceased person to give a kidney to two different people. Then if you have a living donor, they need their other kidney for themselves, so you just get one for them.
When you say you're having kidney failure, which kidney?
They both are failing. The way your blood works is both are failing. There's just some special things where it might be only one, like kidney stones or kidney cancer in just one kidney.
Doctor,
Yes.
for your presentation. How do herbs such as juniper berries kind of clean the kidney or tote or either champapura for kidney stones? I know parsley kind of promotes kidney restoration and function, so I was kind of curious about those particular herbs.
Okay, so there's a lot of herbs I get questions about. You get, not cranberry juice is not a herb, but cranberry extracts and the yeast extract. The one my brother swears could cure his high blood pressure. I'm going blank on it. As much as he talks about it, I bet some people in this room are taking it too. But he also lost a lot of weight and we started him on some blood pressure meds, but he said that herb is the one that did it. So when it comes to kidney disease, any herbs that you buy, make sure you run it through your PCP, your primary care, run it through your nephrologist. There are actually certain ones that we know cause worsening of the kidney function. Some of these herbs can cause this inflammation in the kidney, almost like a allergic reaction in the kidney. Aristocolic acid, which is one that's used in a lot of herbs and things, different things like that, could be associated with worsening kidney function. But a lot of the other herbs, though, I'm willing to take a holistic approach with the patient, especially if that means they go keep coming to the office and involvement in care. I think sometimes when you have a very negative thought about herbs and stuff, or don't want to work with the patient or patient-centered care, they'll keep the patient from coming. Then they get worse when you're not checking their kidney function and things. So certain things I'm willing to work with. Certain things I have to tell patients sometimes, though, that they probably might be wasting their money if they spending too much on some of these herbs. Now you have another question on kidney stones, though. So you gotta be careful with that one. It depends on the type of kidney stones. There's different types of kidney stones. They're not all the same. So certain things could help with certain stones, but makes other stones worse.
Okay.
So you need to make sure, and also a lot of people with kidney stones only see the urologist. So those are surgical specialists. So they want to break up the stone, they want to operate, they want to take the kidney out if you got stones. But I actually recommend people see a nephrologist too. We do like special urine tests and try to figure out exactly which type of stone you have and can make some diet changes or even some other medication that you can possibly use.
Dr. Cobb, you mentioned, I'm here, you mentioned about monitoring your kidney functions if you're at higher risk. How often should we be seeing you if we are at higher risk or having some of those higher risk factors?
I only see patients when they have chronic kidney disease and their PCP should be referring stage 3, definitely stage 4, okay? But you should be seeing your primary care though at least once a year, and that's without chronic kidney disease. Everybody in this room should be getting their kidney function checked at least once a year, and that's the blood work and the urine. Because everyone in this room is considered high risk.
One question.
Dr. Cobb, good afternoon. Great presentation, by the way. Question, I suffer from gout, and it's triggered because of elevated uric acid levels. So does elevated uric acid levels also potentially impact the kidney?
The levels have to be really high to impact the kidney. But the other way around though, patients with chronic kidney disease have increased risk of gout. Your body's not eliminating uric acid, and the kidney is like not eliminating uric acid, you are increased risk of gout. And another thing with gout, be careful with the medications you use for gout. Some of the medications, especially pain medications like the NSAIDs, can make kidney function worse. And the gout medications like allopurinol or uroloric, they're great for gout, but if your kidney function is lower, we need to decrease the dose. Because if you stay on the higher dose, you can have bad side effects from those medications.
Okay, thank you. Dr. Cobb, thank you again for coming. Really appreciate it. Very timely for me. I'm just recovered from stage 1 kidney cancer last year, and I'm 100%, and I'm good to go. But the other kidney, I had to have one of my kidneys removed, and the other kidney.
Excellent. What's your question?
I wasn't getting that. The question is around elevated creatine in my other kidney. And the issue is, or the question, should I say, is about water consumption and things I can do to help lower that other side. And then also any referrals you might have for a nephrologist in town, because I can't find one. I can, but it's taking me months to get signed on. So, and I was hoping you'd say you.
Emory nephrology, we definitely open and we can help with referrals. I can help get people in if they need to too. But I'm glad you recovered. So when you take one kidney out, your kidney function decreased by 50%. No. The other kidney can ramp up its production. Most patients that have one kidney taken out, probably, if everything goes well, might lose about 20 or 25% of their kidney function. But I have patients in clinic who I see who only have one kidney, who have lower kidney function. So if you have high blood pressure, making sure you control that. Some patients might not have high blood pressure before, but when you only have one kidney, the kidney plays a lot in controlling blood pressure. So they might develop high blood pressure afterwards. Water consumption, hey, water is great for high blood pressure, it's great for diabetes, because there's no salt and no sugar. So get as much water you can get in, but definitely try to get 1.5 to 2 liters in. And you're gonna have to be really careful with over-the-counter pain medications if you only got one kidney, even more so than other people.
Yeah, Dr. Cobb, because you did such a good job in putting your questions up there and answering a lot of our questions.
I never had that before.
Exactly. So I think we have time for maybe 2 more questions. Is that okay with you? Okay, on that side.
Yes, concerning diet, when it comes to fruits and vegetables, which ones do you feel we should be eating more of and ones that we should be eating less of? Also, as we get older, we know our musculature begins to decrease. And we tend to, well, some of us tend to take whey supplements, protein whey supplements. What's your feeling about whey supplements, and should we be taking more of them?
Okay, thank you. So when it comes to diet, it's different between someone who's trying to be preventative and early versus somebody with chronic kidney disease. So if you got chronic kidney disease, you definitely gonna need to talk to your primary care or your nephrologist about more specifically your diet. But if you have normal kidney function or trying to be preventative, a lot of the diets that are high in fruits and vegetables and Mediterranean diets, those diets are definitely better when it comes to, I think, preventing things such as worsening blood pressure, worsening diabetes, and chronic kidney disease. When it comes to the supplements, I include whey in the same area with the creatine supplements, okay? So if you've got chronic kidney disease, do not take them. If you do not have chronic kidney disease, I don't imagine you're taking them 4 or 5 times a day before your workouts and lifting a lot of weights. You're probably okay if you don't have chronic kidney disease.
Okay, we have one more question. Okay.
Yes, my question is dealing with, what is your approach on, if you have a patient that had, multiple lesions of cancer on the kidneys? I heard you, mention earlier about removing kidneys. In some cases, you may be able to save the kidney. So my question is dealing with your approach. If someone had maybe 2 or 3 lesions of cancer in their kidneys, do you automatically remove the kidney, or do you try your best to save the kidney? And if you do save the kidney, how do you proceed on with taking care of the kidney going forward?
So it depends on where they're located. And I think that's why I asked that question about was it a full nephrectomy or total nephrectomy versus a partial. So some places like at Emory, we have interventional radiologists and urologists who are able to do partials, where they only take out the lesion, but then they have to So because they're trying to spare the rest of your kidney. If you have them on both sides, and there's a lot of them, I had a patient like that recently. We took an approach where as long as it was, he got imaging done every 6 months, as long as the tumors were in the kidney, we did not do anything to him because if you take both kidneys out, you gotta start dialysis right away. So the patient saw us, he saw urologists on a regular basis, and we just watched. But depending on where they are, partial nephrectomies, depending on how much they have to take out afterwards, it depends on what stage of chronic kidney disease you'll have then. But you will have chronic kidney disease, they have to remove part of your kidney.
Okay, excellent. Thank you so much again, Dr. Wilson.
Final call for forms of any kind. Okay, John, you ready?
I always want to say thank you for coming, and the people who brought a guest, thank you again. I tell you all the time, I see a room of women all the time, and it's a pleasure to be with the men and just showing them what I do over these 28 years. So, and also I want you to know, the first of the year, I'm launching over 500 some videos. It is only 5 minutes. And the mantra is no more excuses. From home workouts, beach workouts, chair, office, truck driver fitness, car fitness. We actually in the car office, anything you can do. Besides the bed, anything in the bed. I don't want nobody to have no more excuses. Only 5 minutes. And to be creative, you'll never get bored again. But let's get started. And if you do, all the motions I'm doing, I'm emulating the scenes of the gym. I'm just not up here just busting moves. I'm thinking about a gym and the concepts of hamstrings, quads, hips, waistline, rear delts, shoulders, lats, upper chest, mid chest, lower chest. And we're going to be stretching as well. But let's warm up this body. Here we go. What's that you playing? Sound like something. It should. Okay, let's break that circulation. Oh, I don't know myself anymore. Feels like the walls are all closing in, and the devil's knocking at my door. Oh, out of my mind. How many times did I tell you I'm no good at being alone? Yeah. need y'all to feel the truth. Come on now. We're not turning into a bad boy. Come on now. Watch this. Get down. Hey man, I'm hot. We need to stretch every day. Put on your favorite song. Talk like that.
This is my decision. I don't think you listen. I don't think you listen.
Switch.
I need you, come on. It must be my teacher. It must be my teacher. It must be my okay. I need you, come on. Because I love you, I want to show you my love. You are a friend, I need to believe.
Two times. 1, 2, 1, 2, 1, 2. Let's go. Oh! Watch it, watch it, watch it, watch it. Oh! 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 Other way! Watch it now, watch it. Go! Give him a show! Give him a show! Watch it. Loosen that back up. Press. Now finish it, y'all. Let's get this over by. I gotta turn my head around, man. I'm gonna go to work. Let me know about the music. Hey, Frank girl. You mixed up. Let's go. Good chance. Good chance. I'm let's go. Good window. Good outer chest. Let's go. Watch this. Watch this. Good concept. Good concept. Watch this. Watch this. Watch this. here. I'm giving y'all a 5-second countdown. That's it. 5, 4, y'all know me up. 3, 2. I don't know if you're from Atlanta or not.
Yeah,
I'm
John.
a true Atlantean. Adamsville.
Yeah. Ready, baby.
We're going that way. If you can skate, we're gonna take it back to Jelly Bean. Come on, come on. Please don't break out. Please don't break out. Right here. Come on. Watch it. Please. Come on. Watch it. I'm always doing first. Watch it. Come on.